Imagine the sheer elegance, the raw power of a horse, thundering across a field, just a picture of health and vitality. Now, picture that same magnificent animal, maybe just days later, suddenly stumbling, disoriented, maybe pressing its head against a wall, or worse, unable to stand at all. This isn't just heartbreaking for owners, it's a terrifying reality brought on by, well, unseen threats. We're talking about something often called sleeping sickness, a condition that can turn a healthy, vibrant horse into a neurological patient almost overnight. And chillingly, it can even pose a serious risk to us, to humans. Today on the deep dive, we're going to unravel the complexities of equine encephalitides. Specifically, we'll focus on Eastern equine encephalitis, known as EE, Western equine encephalitis, or WE, Venezuelan equine encephalitis, VE, and the widely recognized West Nile virus, WNV. These are all severe, often fatal viral diseases that cause destructive inflammation of the brain and, well, sometimes the spinal cord too, in horses. Our mission in this deep dive is to give you a really clear, comprehensive understanding of these complex diseases. You know, what they are, how they spread, what symptoms to watch for, the challenges of getting a diagnosis, the, frankly, grim realities of treatment, and most importantly, the proactive steps you can take to prevent them.
And it's crucial to understand why this matters beyond just, equine health.
Yeah.
The reason these are such a critical topic is that they're zoonotic.
Zoonotic, meaning?
Meaning they can spread from animals, in this case horses, to humans. So protecting horses isn't just good animal husbandry, it's a vital component of public health.
Right. That puts a whole new light on prevention, doesn't it? It really makes it a community health issue.
Yeah.
And to guide us through this, our deep dive is built from comprehensive veterinary texts and cutting-edge research. So let's unpack this. Let's dive into the fascinating, albeit alarming, world of equine encephalitides.
Okay. So at their core, encephalomyelitis, it's a bit of a mouthful,
Yeah.
are conditions where specific viruses cause significant inflammation and damage within the brain and spinal cord. This often leads to severe neurological issues. We're primarily focusing on 4 major players in this category that impact horses across North and South America: EV, WEGI, VEV, and WNV.
You mentioned EEV first. What makes Eastern equine encephalitis so incredibly dangerous? I've heard it described as like one of the most potent neurotropic viruses out there.
That's absolutely right. EEV is considered one of the most pathogenic neurotropic viruses known. Neurotropic basically just means it specifically targets and, well, devastates the nervous system, the brain and spinal cord. When it strikes horses, its mortality rate is incredibly high. We're talking 75% to a staggering 100%.
Wow, up to 100%. That's terrifying.
It is. And geographically, you typically find EEE east of the Mississippi River, particularly along the Atlantic and Gulf coasts. But, and this is concerning, we're now seeing larger, more frequent outbreaks further north in the USA and even into Canada.
And are certain horses more susceptible?
It seems young horses, foals, and yearlings may be a greater risk, yeah.
So it's incredibly deadly, and it's also expanding its territory. How does Western equine encephalitis, WEE, compare? Is it as bad?
Western equine encephalitis, or WEE, is less virulent than EE, thankfully. Its mortality rate is lower, though still very significant, around 20–50%. Historically, it was quite prevalent in the western and central U.S., but surprisingly, actual equine cases are now quite infrequent.
Really? Why is that?
It's not entirely clear. Could be vaccination, could be changes in the virus or vectors. But it's worth noting that Highland's J virus, which is a WEEV variant, still actively circulates in Florida, so it hasn't vanished completely.
Okay, less common now, but still around. Then there's Venezuelan equine encephalitis, VEE. Does it follow a similar pattern?
VE's virulence can vary quite a bit, actually. The mortality rates range from 40% up to 90%. It's endemic, meaning it's constantly present in parts of Central and South America. And we see sporadic outbreaks reaching into Mexico and even occasionally in the southern U.S., places like Texas and Florida.
What's really striking about VEE, though, from what I've read, is its unique role in how it spreads. Can you explain that? Why aren't horses just dead-end hosts with VEE like they usually are?
Ah, yes. What's fascinating here is that VEE is truly unique among these arboviruses, these insect-borne viruses. Usually, a horse gets infected, gets sick, but doesn't have enough virus circulating to infect another mosquito that bites it. That's the dead-end host idea. But during VEE epidemics, horses are not dead-end hosts.
Okay, so what happens?
They can develop the really high viral load, what we call viremia, just lots of virus circulating their bloodstream. High enough, in fact, to transmit the virus back to mosquitoes that feed on them.
Wow.
This effectively makes them amplifying hosts for the disease. They directly contribute to spreading it further and faster. This unique situation often involves virus mutation and changes in both the mosquito vectors and the usual reservoir hosts, allowing the virus to replicate explosively in horses.
So just to clarify, for EEV, WE, W, and V, horses are mostly victims. They get sick, but they don't really spread it further via mosquitoes.
Generally, that's correct. Their viremia is usually too low or too brief.
But for VEE, they can become like a temporary virus factory fueling the outbreak. That seems like a crucial difference for trying to control it.
Precisely. It changes the entire dynamic of how an outbreak unfolds and how we have to respond.
Okay, and then the last one you mentioned, West Nile virus, WNV. That one feels more familiar to many people.
Yes, WNV really burst onto the scene in the U.S. back in 1999. It has since become the most widespread and common arboviral encephalitis in North America. The mortality rate in horses is about 33%.
Still significant, but lower than EE or VE.
Definitely lower, yes, but much more widespread.
So we're talking EE, VE, and WNV primarily as concerns for North and South America. And you mentioned the incidence often spikes geographically, I assume linked to weather, mosquito season.
Exactly. Peak mosquito season is peak risk season. Weather conditions play a huge role in mosquito populations.
And it's those mosquitoes that really drive how these viruses get around. So let's talk about that transmission cycle. It sounds pretty intricate.
Right. They're all arthropod-borne viruses, or arboviruses, plain English. Insects, mostly mosquitoes, transmit them. It's quite a life cycle. Wild birds are the primary natural reservoirs, the places the virus normally lives, for E, WE, and WNV. For VEV, rodents often serve as reservoirs for the endemic, less severe strains, and bats can also carry it.
Okay, so the virus hangs out in birds or rodents, and then the mosquitoes come in.
Exactly. An infected mosquito feeds on one of these reservoir animals, picks up the virus. Then it acts as a bridge vector, carrying the virus and transmitting it when it bites what are usually dead-end hosts, like horses and humans.
And just to reiterate, dead end means we get sick, horses get sick, but we typically don't have enough virus in our blood to pass it back to another mosquito.
Correct. Except, as we highlighted, for that epizootic VEE, the epidemic kind. That's the major exception where horses do become those amplifying hosts.
Got it. So once an infected mosquito does bite a horse, how does that one bite lead to such devastating neurological problems? What's happening inside the horse's body?
Well, after the bite, the virus first replicates locally, right near the bite site. Then it enters the bloodstream, that's the viremia stage we talked about. In susceptible horses, the virus then manages to cross a critical barrier, the blood-brain barrier, to get into the central nervous system.
The blood-brain barrier, that's like the brain's security system, right?
Yeah.
Highly selective.
Exactly. It's designed to keep harmful things out. But these viruses, unfortunately, find a way to breach it. Once inside, the viral replication within the brain and spinal cord tissues triggers intense inflammation. It damages the neurons directly and causes swelling or edema. And it's this inflammation, damage, and swelling that then cause all those characteristic neurological signs we see. If we connect this to the bigger picture, you can really see how this intricate cycle highlights just how closely linked animal health is to environmental factors, like mosquito populations and ultimately to public health.
Yeah, it's a prime example of that one health concept, isn't it? The interconnectedness of animal, human, and environmental health.
Absolutely. What happens in one sphere directly impacts the others.
So when a horse does get sick, what are the red flags? Given how devastating these can be, catching them early sounds absolutely vital. What are the very first signs an owner might notice, maybe even before things get really scary?
The onset is usually quite acute, pretty sudden. Typically appears anywhere from 5 to maybe 15 days after the mosquito bite. Initially, you might just see some nonspecific signs, often kicking in about 48 to 96 hours before the obvious neurological symptoms. Things like a fever, maybe loss of appetite, the horse seems depressed or lethargic, maybe some stiffness. Some horses might even show lameness or signs that look like colic, abdominal pain.
But those symptoms could be a lot of things, right? Fever, off-feed, pretty common signs. When do the real alarm bells start ringing? What are the progressive neurological signs that point more specifically towards these encephalitides? What does that sleeping sickness actually look like?
That's right. The early signs are vague. The real alarm bells go off with the progressive neurological signs. While these can vary in severity, they often point to diffuse disease in the brain, though sometimes spinal cord signs might be more prominent, especially with West Nile. You might see behavioral changes like somnolence, that classic sleeping sickness look, particularly with EE. The horse just looks profoundly dull, sleepy. Or they might seem demented, Start pressing their head against walls or posts, wander aimlessly, maybe walk in circles.
Head pressing. That's a pretty distinct sign, isn't it?
It's a very concerning sign, yes. It often indicates serious brain involvement. Motor deficits are also very common. You'll see ataxia, which is incoordination, stumbling, wobbling. Weakness or paresis, which is partial paralysis. They can move, but with difficulty. Muscle tremors are another big one, especially around the face and muzzle, or muscle twitching. We call that fasciculations.
And problems with nerves controlling the head.
Yes, cranial nerve deficits. These can show up as drooping eyelids, maybe one side of the lip is weak or drooping, lip paresis, or dysphagia, which is difficulty swallowing that's very serious because of the risk of aspiration pneumonia. And horses might show proprioceptive deficits. Basically, they lose awareness of where their limbs are in space. They might stand awkwardly or lean into a wall without correcting themselves.
And in the really severe cases.
In severe cases, you can see seizures, quite common with blindness, and eventually recumbency. That's when the horse simply can't stand up anymore, progressing to lying flat out on their side, maybe paddling their legs.
That sounds incredibly distressing to witness.
It is. And while less common, sometimes you see the opposite. Hyperexcitability, or even mania, particularly with VEE. The horse becomes dangerously agitated.
Any other associated signs?
You can sometimes see abortion in pregnant mares, maybe oral ulcerations, pulmonary hemorrhage, or nosebleeds, epistaxis, but the neurological signs are primary.
Okay, that's a lot to watch for. But I guess the key takeaway for any horse owner or caretaker is that any unexplained neurological change, especially during mosquito season, should be treated as an immediate emergency.
Absolutely. Don't wait. Call your veterinarian immediately.
So the vet arrives. How do they go about pinpointing the problem, especially when, as you said, other things can look similar? What's the diagnostic challenge?
The diagnostic process really relies on combining clues. First, those characteristic clinical signs we just discussed. Second, considering the geographical location and the season. Is it mosquito season? Is this disease known to be in the area? And third, the horse's vaccination status. Is the horse vaccinated? An unvaccinated horse showing these signs in an endemic area during mosquito season is unfortunately a prime suspect.
So history and clinical signs get you partway there, then come the lab tests, right? I understand blood tests are key.
Yes, laboratory diagnostics are crucial for confirmation. For a live horse showing acute signs, the IgM capture ELISA on a blood sample is generally the preferred test. IgM antibodies are the first type the body produces during an active infection. So, detecting high levels of IgM specific to one of these viruses is strong evidence. A titer, which is a measure of antibody level of 400 or more, is usually considered confirmatory in a sick animal.
What about other antibody tests?
We also look for IgG antibodies. IgG levels rise later in the infection and can persist longer, sometimes even after vaccination. So we often take 2 samples, an acute sample early on and a convalescent sample about 7 to 10 days later. If we see a 4-fold or greater rise in the IgG titer between those 2 samples, that confirms a recent infection.
But you mentioned vaccination status. Does that complicate interpreting these tests?
It certainly can, especially with IgG. A single high IgG level might just reflect vaccination, not active disease.
Right.
That's why the IgM test or the paired IgG samples are often more informative for diagnosing a current case. Also, there could be some cross-reactivity between, say, EE and WE antibodies, so specific ratios are sometimes used. For E, if the E titer is 4 times higher than the WE titer, it's suspicious. If it's 8 times or more higher, it's highly indicative of EE.
Okay, so blood tests are important but need careful interpretation. Are there other tests, maybe looking at the nervous system more directly, like a spinal tap?
Yes, a cerebrospinal fluid analysis, getting a CSF sample via a spinal tap, can be very helpful. We look for things like elevated protein levels and an increased white blood cell count. We call that pleocytosis. Both indicate inflammation within the central nervous system. And that CSF fluid itself can also be tested for virus-specific IgM antibodies, or even for the virus's genetic material, the RNA, using PCR.
PCR polymerase chain reaction, that detects the actual virus.
Exactly. It detects the viral RNA. PCR could be done on CSF or postmortem on brain tissue. It's generally less reliable on blood samples from live horses with E, DDUEE, or WNV because the viremia, the virus in the blood, can be very short-lived. By the time neurological signs appear, the virus might be gone from the blood.
And sadly, if a horse doesn't survive, postmortem diagnosis is more definitive.
Yes. Postmortem examination is often the only way to get a completely definitive diagnosis. Histopathology, which is looking at thin slices of brain and spinal cord tissue under a microscope, reveals characteristic damage patterns. And then techniques like immunohistochemistry or PCR on that tissue can directly confirm the presence of the specific virus.
This raises an important question. You mentioned other diseases can look similar. How crucial is it to rule those out?
It's absolutely vital, especially ruling out rabies. Rabies presents with neurological signs. It's almost always fatal. And critically, it's zoonotic. Humans can get it from infected animals. So rabies has to be considered in any neurological case like this.
What other lookalikes are there?
Other important ones include equine herpes virus, myeloencephalopathy, or EHM, which is caused by EHV1 virus. There's equine protozoal myeloencephalitis, EPM, caused by a protozoan parasite, botulism, certain toxicities like leukoencephalomalacia from moldy corn, head trauma, even tetanus. It's also worth noting, as I mentioned, that West Nile virus often causes less severe brain signs and more prominent spinal cord signs like weakness and ataxia compared to the profound dementia you might see with EE. But there's overlap.
That's a critical point. Misdiagnosis could be devastating, especially if it was rabies. Okay, let's say we do have a confirmed case of EE, VE, or WNV. What's the reality? What's the road to recovery or not for these horses?
Well, this is the really tough part. The hard truth is there is no specific antiviral treatment or cure for any of these equine encephalitides.
No cure. So treatment is what? Just supportive.
Exactly. Treatment is entirely supportive. It's focused on managing the clinical signs, reducing the inflammation, and preventing secondary complications while the horse's body tries to fight the virus if it can.
So it really comes down to intensive nursing care. What does that involve?
Intensive nursing care is absolutely paramount, especially for horses that go down become recumbent. This means incredibly diligent care to prevent things like decubital ulcers, those awful bed sores, muscle wasting or atrophy, and aspiration pneumonia, which can happen if they have trouble swallowing. They need frequent turning, maybe every 2 to 4 hours. Deep, soft bedding is essential. Padded stalls can help prevent injury.
How do you manage hydration and nutrition if they can't eat or drink?
That's critical. Often it requires intravenous fluids to maintain hydration. Sometimes, if they can't swallow but their gut is working, nutrition can be provided via a nasogastric tube. For horses that are weak or ataxic but still trying to stand, sling support can sometimes be used, but that requires very careful management too.
And what about medications? Can anything help manage the symptoms, the inflammation?
Yes, medications are used supportively. NSAIDs, non-steroidal anti-inflammatory drugs like Flunix and Miglumin, brand name Banamine, are commonly used to reduce fever, pain, and inflammation. Corticosteroids, like dexamethasone, are sometimes used to try and reduce brain swelling, the edema. But their use is a bit controversial because they can also suppress the immune system, which might hinder the horse's ability to fight the virus.
A double-edged sword.
It can be. If the horse is having seizures, then anti-seizure medications like diazepam or phenobarbital might be needed. Muscle relaxants sometimes help with severe tremors. And importantly, broad-spectrum antibiotics are often given, but only to prevent or treat secondary bacterial infections, like pneumonia or skin infections from sores. They have absolutely no effect on the virus itself.
And you mentioned preventing self-injury earlier.
Yes, that's a big concern for horses that are ataxic, stumbling around, or having seizures. Padded stalls are crucial. Sometimes helmets are used, protective bandaging on their legs, anything to minimize self-trauma.
It sounds like an immense amount of work and resources. And the prognosis. You touched on the mortality rates earlier. It sounds pretty grim, especially for E.
It is, unfortunately. For E, the prognosis is grave to poor. With that 75–100% mortality rate, survival is unlikely. Complete recoveries are incredibly rare. Survivors, if there are any, often have severe, permanent neurological problems, clumsiness, persistent depression, maybe abnormal behaviors. Honestly, E horses rarely survive long enough for much follow-up testing.
So EE is almost always a death sentence or results in profound disability. What about the others?
For EE, the prognosis is guarded to fair. The mortality rate is lower, 20–50%. Survivors may still have some residual deficits, but they often recover more completely than E cases. For VE, the epizootic epidemic strains, it's guarded to poor, with that 40–90% mortality. Survivors often have permanent deficits. The less common endemic strains generally have a better prognosis.
And West Nile.
West Nile virus is generally fair to good. The mortality rate is around 33%. Many horses do recover fully, perhaps with supportive care. However, some may have long-term issues like gait abnormalities or behavioral changes. And importantly, WNV horses that become recumbent, unable to stand, have a much poorer prognosis than those that stay on their feet.
It sounds like a truly tough situation for both the horse and their owner. It must lead to some very difficult conversations and decisions, especially considering the intensive care needed and the potential for long-term disability in survivors.
Absolutely. The ethics of providing prolonged intensive nursing care for a horse that may have severe permanent neurological deficits is something that always needs to be discussed openly and honestly with the owner.
But there is hope, and that hope, it sounds like, lies squarely in prevention.
Absolutely. Prevention is, without a doubt, the most effective weapon we have against these devastating diseases.
And the cornerstone of prevention is vaccination, right? Why are EEWE and WNV considered core vaccines by the AAEP, the American Association of Equine Practitioners, for basically all horses in North America?
They're designated core for a few key reasons. One, the diseases they prevent are serious, often fatal. Two, they have that zoonotic potential, posing a risk to human health. And three, they have a widespread geographic distribution, meaning many horses are potentially at risk.
So baseline protection for pretty much every horse. What about the VE vaccine? Is that core too?
No, the VEE vaccine is considered risk-based. It's typically only recommended for horses living in or traveling to endemic areas, primarily in Central and South America or parts of the southern U.S. where outbreaks might occur. Often it's primarily available only during an active outbreak situation.
Okay, so for the core vaccines, EE, WEE, WNV, what's the typical schedule?
The usual protocol starts with an initial series of 2 doses, typically given about 3 to 4 weeks apart. After that initial series, an annual booster shot is recommended. Ideally, this booster is given in the spring, before the mosquito season really gets going in most areas.
And what if you live somewhere with year-round mosquitoes, like Florida or the Gulf Coast?
Good point. In those highly endemic areas, or for horses with significant year-round mosquito exposure, veterinarians often recommend semi-annual boosters, so every 6 months, to maintain higher levels of protection.
And what about foals? When do they start?
Foals born to vaccinated mares usually get some temporary protection from antibodies in the mare's colostrum, the first milk. They typically start their own vaccine series around 4 to 6 months of age, often needing a 3-dose initial series. Foals from unvaccinated mares might start earlier. Your vet will tailor the protocol.
How effective are these vaccines? Do they guarantee a horse won't get sick?
The vaccines are highly effective at preventing clinical disease, the severe neurological illness. They significantly reduce the risk of sickness and death. However, it's important to know they don't necessarily prevent infection altogether or stop that brief viremia phase in all cases. A vaccinated horse might still get infected, have a low level of virus briefly, but not develop the severe brain inflammation.
So even if vaccinated, a horse could technically get infected, just not sick. And does that mean survivors should still be vaccinated?
Yes, exactly. And reinfection is possible even in horses that survived a natural case. So the recommendation is definitely to continue vaccinating survivors according to the regular schedule.
Okay, vaccination is number one. But it sounds like controlling the mosquitoes themselves is the other critical piece of the puzzle.
Absolutely. Strict mosquito control is vital. It protects not just horses, but people too.
What are the key things horse owners can do around their property?
The absolute #1 thing is to eliminate breeding sites. Mosquitoes need standing water to lay their eggs, so get rid of all sources of standing water. Dump out old tires, buckets, containers, keep gutters clean, fix leaky faucets or troughs, improve drainage in low-lying areas of pastures. Even small amounts of water are enough for them.
What about water sources you can't easily eliminate, like ponds or water troughs?
For water troughs, clean them regularly. For larger bodies of standing water that can't be drained, you can use larvicides. Products containing Bacilli, Bacillus thuringiensis israelensis, are very effective. It's a naturally occurring bacterium that kills mosquito larvae, but is safe for other animals than fish.
Fish? Can they help?
Yes. If you have ponds, stocking them with mosquito-eating fish, like gambusia or minnows, can be a great natural control method.
Okay, eliminate breeding grounds. What about protecting the horses directly?
Directly protecting the horses is also key. Bring horses inside barns or stables during peak mosquito feeding times, which are usually dawn and dusk. Using fans inside barns helps a lot. Mosquitoes are weak flyers and dislike moving air. Make sure screens on barn windows and doors are intact and well maintained. Applying effective approved equine insect repellents daily, especially during high-risk periods, is important. Follow the label directions carefully. And physical barriers like fly sheets and fly masks can provide significant protection, especially for horses that live outdoors 24/7.
Are there things you can do to treat the premises, like around the barn?
Yes, you can use residual premise sprays or automatic fogging systems in and around barns. These products kill adult mosquitoes that land on treated surfaces. Again, always read and follow the product label instructions for safety and effectiveness. What's fascinating here, really, is how multi-layered prevention needs to be. It's not just one single thing. It's vaccination plus eliminating water, plus repellents, plus barn management. It's a holistic approach that truly makes the difference.
It really underscores the need for vigilance, and you mentioned monitoring reports.
Yes, it's important for owners and veterinarians to stay informed about arboviral activity in their region. State public health departments and agriculture departments usually issue reports or alerts when viruses like EE or WNV are detected in mosquitoes, birds, or other animals. And remember, suspected cases of equine encephalitis are typically reportable diseases. This means veterinarians are legally required to report suspected cases to state authorities. Prompt reporting is crucial for surveillance and implementing control measures if needed.
Okay, so as we wrap up this deep dive, the message seems clear. While the threat of equine encephalitis, E, W, V, W, NV is severe, is genuinely frightening, the power of knowledge and proactive prevention is immense.
That's right. Diligent vaccination, following veterinary recommendations, combined with aggressive, consistent mosquito control, those are, without a doubt, the most effective measures we have to protect horses.
And by protecting horses, we're also adding a layer of protection for ourselves and our communities, given the zoonotic nature of these diseases.
Exactly.
Now, considering what you said earlier about these outbreaks appearing in new, more northern locations, and how climate change might be influencing mosquito populations and ranges, it makes you wonder. This raises an important question, perhaps a final thought for our listeners. How might our understanding of these specific mosquito-borne diseases in horses serve as a kind of early warning system, a vital indicator for broader ecological shifts, maybe even the emergence of other zoonotic threats?
That's a really thought-provoking point. What can we learn about environmental changes from the movement of these particular viruses? And how might that knowledge better inform our preparedness for future challenges impacting both animal and human health in this interconnected world?
Food for thought indeed. Keep learning, stay curious, and stay vigilant about the health of the animals in your care and the environment around you.